Hey, this is Dr. Nick with the ECG Academy, and we're going to start a new section on atrial tachyarrhythmias. That means fast heartbeats coming from the top chambers. That's all that means. Atrial referring to the top chambers, tachy meaning fast. All right, now there's a whole bunch of different kinds of atrial tachyarrhythmias, and the videos in this section are going to discuss each and every one of those and try to put things into perspective. So, what I've done here with this pie chart is give you an idea of how often you'll see the different kinds of tachyarrhythmias. Atrial fibrillation is a very common atrial tachyarrhythmia that has its own section in this basic ECG course. Atrial fibrillation occurs when the electrical signal in the top chamber is going all different directions in a very disorganized, chaotic fashion. And that causes a very specific type of rapid heartbeat coming from the top chamber. Atrial flutter, on the other hand, is a rapid heartbeat coming from the top chamber where the electrical signal is basically traveling around in a circle, and the atrial rate is somewhere between usually 225 to 325 beats per minute, somewhere in that range. Anything slower than that will generally fall into the category of supraventricular tachycardia or atrial tachycardia. Atrial tachycardia is generally an abnormal rhythm originating in the top chamber at rates anywhere between 100 and 200 beats per minute. It can be faster as well, but when it gets over 225 or so, we start to think of it more like as atrial flutter. Although you'll see that sometimes it's kind of hard to tell the difference, and it's really kind of a matter of what you'd like to call it, depending upon what it looks like. So this section is going to be talking primarily about atrial tachycardias as a type of supraventricular tachycardia. That's what SVT stands for. Supraventricular just means it comes from above the atrium. So this includes a whole bunch of different kinds of atrial tachycardias, including some that actually originate from the AV node itself. We'll talk about those in more detail in the advanced course, but for now we'll show you what they look like and familiarize you with how to diagnose supraventricular tachycardia. Well, in the grand scheme of trying to organize this discussion of atrial tachyarrhythmias, there'll be 4 chapters. This chapter is going to be about atrial tachycardia and paroxysmal supraventricular tachycardia. The two of these are often grouped together because sometimes it's hard to tell the difference. But let's just say that atrial tachycardia, you can generally see the P waves in front of each beat, whereas in PSVT, the P waves may or may not be apparent. So we're going to start with our first strip here. And in this rhythm strip, if you kind of glance across and look at the forest, you'll see that there seems to be a sinus beat that kind of stands by itself in the beginning. And then suddenly it appears that the heart rate increases significantly. This sinus beat does have a P wave in front of it, and the PR interval looks to be at the upper limits of normal, probably 180 to 200 milliseconds. And the next sinus beat seems to be over here, with a heart rate about 300, 150, 175, 60. So it's a little bit faster than 60 beats per minute, probably 65 or so beats per minute. And you'd expect the next beat to occur in here someplace, but you can see that there's a P wave here that starts off something here, something rather fast. The first beat occurs somewhere above 100 beats per minute, but you can see that there's a slow increase in heart rate. By the end of this, we're talking about just over 150 beats per minute, like maybe 155. One thing you can characterize this as having a gradual increase in heart rate. It's a rapid heartbeat, so it's a tachycardia. You see P waves that start the tachycardia, and the QRS complex looks exactly the same as the underlying QRS complex. So it would appear to be coming from above the ventricles, so it's supraventricular, and you see this P wave that starts it off, so it's appropriate to call it atrial tachycardia, or AT for short. Now, one thing about atrial tachycardias is they can occur at rates anywhere from 100 up to 220 beats per minute. This one happens to have a particular pattern in that it warms up. A warm-up phenomenon means that the heart rate gradually increases as the arrhythmia progresses. Now, what you need to start doing now is pay attention to the little bitty details, because this is how you'll make the diagnosis. If you look in front of this beat, this beat looks the same as that beat, so where did it come from? You'll see that this T wave, which was very smooth, and if you compare it to this T wave, what do we see? We see a bump. And that bump, of course, is the P wave that gave rise to this QRS complex. So clearly there's a P that is in front of this beat, and if we look at the next one, we see a P here, and we see a P here. So there are P waves preceding each beat, and it starts to get interesting as you get to the end of the tachycardia. Because where are these P waves? Well, I think it's clear that there's one here, but now what happens is there are two bumps. Now, which is the P and which is the T? You'd expect that maybe this is the P because it's in front of the QRS complex. But remember, we have a PR interval that's somewhere out in the 180 to 200 millisecond range. So if you measure back from this QRS complex, you'll see that this is probably the P wave. And you'll say, nah, come on. Are you sure about that? And I'll say, well, look at the next one. Now you still see two bumps, but they're much further apart. Which one has moved? Which one looks like it's associated with the QRS? You figure, well, I think that's the P wave because that's closer to the QRS. But it turns out that this is the P. Now, how can you say that? How do you know that? Well, it wasn't here. And it's unlikely that the T wave moved because the QT interval cannot suddenly shorten. So because this is the signal that's moving, it's likely that that's the P wave, but I can prove it to you. Because when you look at this beat, you can see a bump right there, and that cannot possibly be the T wave because that QT interval is not physiologically possible. And this conducts to this QRS with a fairly long first degree, somewhere about 280 milliseconds, and then this happens to be the last beat of the tachycardia because here there's no P wave, but what you do see is a T wave that looks exactly the same as this T wave. This T wave and this QT interval is the same as this QT interval and this T wave. So this T wave, that's the T right here, and the P wave is this bump that comes after the QRS. Isn't that cool? So if you carefully dissect this strip, you can get the sense that the P's can march around and they can change their position with respect to the previous QRS complex, and that gives you a hint that that's the P. It's kind of marching on through. But in fact, what we had here, if you count this as the first beat, you have 1, 2, 3, 4, 5, 6, 7, 8 beat run of atrial tachycardia with a warm-up phenomenon that started at 100 beats per minute and sped up to about 155. At the end, had a bit of a first-degree AV block, but that's exactly what you would diagnose this tachycardia as. So we are getting into some complicated territory over here, and I hope you guys keep up. But the beauty of internet learning is that you can play this back over and over again until you truly get it. Get it? All right. Let's go on to the next one. This one might be a little bit easier to see, but it does have a slightly different flavor here because the QRS is wide. This patient has an underlying bundle branch block, and that makes the QRS duration somewhere about 120, 140 milliseconds. But clearly you can see P waves that precede these QRS complexes, and it looks like you have a normal sinus rhythm at a rate of about 70 beats per minute. You have an atrial premature beat here. You can see there's a P in front of it, but it looks kind of pointy compared with this P wave. So it probably came from a slightly different spot in the atrium. And then you have to start to wonder whether this is another P wave because it's a sharp bump that occurs on top of the T. This has to be the T here because it looks the same as this T wave. And so that's another P there that gave rise to this QRS. Then you have a little bit of a pause here, a compensatory pause. So basically what you had here was an atrial couplet. You had 1 and then 2 premature beats in a row that gave rise to this atrial couplet. Now you have a little compensatory pause. You have a very tall P wave here, and some people would call this an escape beat since the P wave looks different morphologically than the sinus P wave. But then this looks more like a sinus P, and we're back to a rate of about 70. And then we start to see another APC, and maybe this is an APC as well that conducted to here. And now you see an abnormal P wave that conducts, and then suddenly the heart rate takes off like a shot. Now what we have is a heart rate of about 145 beats per minute, and it's quite steady heading on. In fact, at this point, you have 150 beats per minute, and it's still running until right here when it ends, and you have a compensatory pause. You have no P wave here, so most likely this is a junctional escape. And then there's an APC right here that gives rise to this QRS. And then you have a P wave that conducts, another P wave that conducts, and you kind of have, you're not exactly back to sinus rhythm. This is obviously a patient with a lot of different complex atrial arrhythmias. But this is the part I want to show you. This atrial tachycardia right here at 150 beats per minute, you can diagnose it because look at these T's. Look how peaked they are. They're a lot taller than this T wave, and that's because you have a P wave buried in the T. There's a P here and there's a P here, and each of these P's conduct antegradally down the AV node, giving rise to the QRS complex. So you have all these P's. Now you're saying, come on, Dr. Nick, how do I know there's a P there? Just because it's tall, what's the big deal, you know? Well, if you keep on looking, look what happens. The P and the T start to split apart, and now you have two bumps. Remember, like the last strip, you had two bumps? The question is, which is the P, which is the T? I have a feeling that the first one is the P for the same reason, that because it's a fast rate, you get a longer PR interval, you get slowing of AV conduction, and the QRS complex will occur late, but the T wave remains somewhat delayed because your QT interval here is pretty long, about 400 milliseconds. But you can see, look at that, how this is a little bit wider, and then it gets a bit more narrow. These two bumps are independent. One is the P, one is the T, and you can pick them out. You can pick out that P wave apart from the T, and you can say, there's a P wave in there, and this is an atrial tachycardia, until it finally breaks here, and then the patient's back in some kind of escape beat, and then a sinus rhythm of sorts. So this is a kind of a tracing that you're going to see on telemetry all the time. What do you call it? Well, you'd be surprised. A lot of monitor techs will look at this and call it atrial fibrillation, but it's not. You can see these discrete P waves marching on through, each one associated with the QRS complex. So what is this? We would call this atrial tachycardia with one-to-one conduction. That's what the correct diagnosis is. It's an atrial tachycardia with one-to-one conduction. You can see that the beats are coming from the atrium. The atrium is driving the ventricles. There's a little bit of irregularity in that the PT intervals are varying slightly. So there's just a slight bit of irregularity to this arrhythmia, which is very common for atrial tachycardias. So that's how you diagnose atrial tach. It is a kind of supraventricular tachycardia, but I think supraventricular tachycardia is a little bit more vague in that it only tells you that it's coming from above the ventricles. Atrial tachycardia is more specific in that it tells you basically that the mechanism is that the atria are beating rapidly. The atria are beating rapidly. It could be due to a focus that's firing, or it could be due to some other kind of short circuit. But the implication in the diagnosis of atrial tachycardia is that the AV node is passively conducting the impulses down to the ventricles. In other words, these electrical impulses are originating in the top chamber, and they go down the AV node to the bottom chamber, and the AV node is not part of the circuit. In other types of supraventricular tachycardia, the AV node is part of the circuit, but that's an advanced topic, and we're not going to get into that at this basic level. At any rate, atrial tachycardia implies it's coming from the atrium, and the AV node is simply conducting the impulses to the ventricle. Now, I've shown you two examples of non-sustained atrial tachycardia. These are bursts, or sometimes we call them salvos, of rapid heartbeats that start and stop. The word that we use in cardiology for arrhythmias that start and stop and start and stop is paroxysmal. A paroxysm is like an attack. It's a non-sustained burst or an episode. So paroxysmal atrial tachycardia, or PAT, is actually the old term we used to use. But I think PAT is overused. It's often used when someone's not sure of the mechanism and they just see this atrial arrhythmia that starts and stops and they call it PAT. But PAT is kind of a generic term, and I prefer trying to get a handle on exactly what the mechanism is of this tachycardia. And in the advanced course, we talk about the electrophysiologic mechanisms of tachycardias, and that helps decide how you're going to treat it in terms of which medications to choose for the patient. In the next video, we're going to talk about sustained atrial tachycardias and the whole concept of paroxysmal supraventricular tachycardia, or PSVT. So until then, this is Dr. Nick for the ECG Academy. Thanks for watching.